there's two things that you need to accomplish. Service connection, yes, all day long. But the thing that is missed so often is this is your opportunity to address what your rating should be. You are the patient, and you should know you better than any doctor. And if you read, as Clay said, the schedule of ratings for your condition, and you can read it. Now, granted, some of the words are super medical terms, and they use weird words, right? If you don't know what it means, Google search it, translate it, and you'll go, oh, that means difficulty swallowing, right? So let's talk about GERD for a second with the C&P exam. So I love that you used migraines. That's one of my favorite ones to use. And now I think that with these two examples, migraines and GERD, this shows you how important your words are. Okay.
Yeah.
It's different than a back condition or something like that, or high blood pressure, because they'll just measure your blood pressure and it is what it is, and you're on whatever medication you're on, or you can bend this far before there's pain. Now, granted, your words matter there, but there is the reality of this is how far I can bend. So you can really screw up your results by not being prepared. Now, being prepared, and I like your algorithm for creating your formula, right? Your algebra to figure out how to do that. And that's really important, because what Clay is talking about here is, imagine if, and we alluded to this at the beginning, if the VA didn't really send all of the relevant information to the C&P examiner. Now you need to bridge those gaps. Like Clay said, you need to have that nexus. The nexus is the link between your diagnosed condition and your time in service, either manifesting during your time in service or as a result of your time in service, is kind of the way I look at it. Now, with GERD, let's say the same example, right? You went through and you have nothing in your military records regarding GERD. So you're trying to, I call it manufacture evidence. Okay, so you've done that to get your claim going. So now you're at the C&P exam. You've gotten your buddy statements. You've gotten, your Nexus letter from your doctor, and you've done all your homework. Now you're at the C&P exam, and I've seen this happen, and it's very sad to run into situations after the fact, because it's always the same thing. I wish I would have known, right? So that's the whole point of this, is to eliminate the I wish I would have known. So what would I tell somebody who's going in? Well, what I would tell them is review that schedule of ratings for GERD. Make sure that you understand where you are in that schedule of ratings, right? You're the patient. You know how bad it is, right? If you rate a 60% rating in your mind because you're reading it and you should rate that, then you should. If it's a 30, then be honest with yourself, right, as you're doing this. And then you need to be able to regurgitate that information at the C&P exam. So you can either write it down, right? Now, if it's a QTC or the other one where they're asking you for that information, this is where you want to take that information and put it in that form that you're going to give back to that C&P examiner. Or you're going to call in and say, hey, I have some additional, additional evidence or statement or whatever that I want to add into the file, right? I'm the patient. You're going to be asking me questions anyway. So if you're able to, great. You're taking that information from that C&P or from that schedule of ratings, taking that information, printing it out, writing it down, whatever, showing up to your C&P exam. Now you're there. Now you're going to incorporate what Clay said, which is you're painting the picture of, in whatever year, in the middle of my time in service, I started experiencing this. It was frowned upon. It's no surprise to the VA or the C&P examiners that going to medical for anything was frowned upon. They hear it 1,000 times a day. So it's not like it's, what? I can't believe you didn't go. Turned a little blue there. I get a little, sad about it. So here you are saying that you have not went to medical or saw a corpsman, saw a medic, went to the battalion aid station or anything like that. You self-medicated, like Clay said. And so now you've done that until you got out. And then 5 years later, after you got out, you saw a commercial with Larry the Cable Guy about Prilosec, and so now you're like, hey, well, maybe that one might help me, and I don't need to eat a bottle of Tums. So you go to the doctor, and finally you get diagnosed, and you get the Prilosec, and all of a sudden it's not as bad. You can actually maybe sleep most of the way through the night instead of choking on hot lava, and so now life's a little bit better. But now you have your diagnosis, and you have your prescription, and you have all that information that you could take in. So you're explaining that it happened during the time of service. I like to say you're kind of explaining why you didn't have it documented while you were in service. You need to explain why, and it needs to make sense. And does the VA get it right, even if the C&P examiner says, at least likely is not? Sometimes the VA still screws it up and goes, well, I see this other thing, and there's nothing really in service, and we'll deny it. And we collectively have probably seen thousands of denials turn into ratings, right? And so this happens, and so you need to be able to stand firmly, knowing what you should be awarded. I feel like I'm going on and on here. I'm going to wrap it up real quick. So the big thing is that knowing the schedule of ratings is important, and being able to tie it back to your time in service in your conversation. Okay, I'm going to give a quick example after I pass it back to you, Clay, but I do have an example of like a veteran A, veteran B piece who's speaking to the VA. But I want to kick it back to you for anything that might have popped in your head on my rant. I'm trying to joust you now with rants. I'm going to work on shortening mine up a little bit.
So there is, and this is actually, this is we'll call it a VA secret. It actually is a VA secret because they don't publicize this. But what raters see on their computer whenever they are deciding a claim, and I know this because I have tons of friends, not tons, I have a few friends that are raters right now, and I speak with them. We're all government employees. It's fine. And so how that process looks, because you mentioned 38 CFR, which is critical, okay? And those symptoms in 38 CFR. So for instance, GERD, if you Google GERD 38 CFR, you're going to find a link that says eCFR, which is electronic, CFR. And then you hit that button, you would word search GERD, not GERD, it would be the gastro reflux disease, whatever the word is. But yeah, there you go. He's got my guy.
Yeah, you don't want to read these. They're a very dry read.
Control F goes a very long way on the internet, but that's how you figure out your symptoms. Those symptoms are on the DBQ, and this is really getting at the VA secret, okay, that raters have. Depending on how that DBQ is completed, right? So if you say I have migraines 3-4 times a month, I think is the criteria for 50%. It might be 4 and 5, whatever number it is. If that's what you say, and more importantly, because we are informed and educated, we told our primary healthcare team that. So now our testimony is supporting our evidence, okay? And not, if you give a testimony in lieu of evidence, the weight of that self-report is not saying it's not important. It's there. It's just not as good as supported by medical evidence, right? So I tell my primary healthcare team I get 4 to 5 migraines per month. Boom, in my VA health records. I go to my C&P exam. I tell them I get 4 or 5 migraines per month. How that translates when that DBQ from the exam company is sent to the VA, it's not AI or machine learning, but it's a automatic software that pops up on your claim that says, hey, at least as likely as not. The system, so the rater doesn't recommend anything. They do, but I'll get to that in a second. The system recommends what it should be, right? So the system will say, hey, this was at least as likely as not service connected. I, meaning the software, is recommending 50%. And so what the rater does, they have 3 options. One, and let's just say migraines at 30% for what I'm about to say next. So let's say the system recommended migraine service connected at 30%. The rater, right, the VSR, now has 3 options to make. 1, accept, based on the evidence, accept the recommendation from the system. Boom, service-connected migraines 30%. Easy peasy, you know, they meet their time quota, claim's done. The second option is to reduce it. So, hey, I know the system recommended 30%, but I'm gonna reduce it, and they have that power. But if they reduce it, they have to justify why, and it goes back to what? Medical freaking evidence. That's why it is critical to have evidence for that claim. And even if they, give you a 10% for migraines or 0%, now you have the higher level review, which to be real does suck. Okay, it happens. The VA is not perfect, but medical evidence is what saves it. It's what saves your claim, right? The third option they have, so they can approve the recommendation, they can lower the recommendation, or they can raise the recommendation. And again, if they raise it, it has to be justified through evidence. So just knowing that VA secret, okay, I think it adds more weight to what you said, Jason, about understanding the symptoms that the VA is looking for, right? It's not that the VA wants, they are looking for that. I think GERD is a fantastic example, and I know you're going to go into that. But if I know the symptoms for GERD, by God, I'm going to have evidence that states I have these symptoms, and then I'm going to give my testimony. So as a CMP examiner is marking that DBQ, all of a sudden it goes back to the VA, and then the prompt says, hey, GERD 30%, right? GERD 60%. That is much, much easier. And it makes not only the CMP examiner's job easier, it makes the rater's job easier. The raters are bound by time quotas. Whether you agree with it or not, that is, that's neither here or there, but they have time quotas. They have to punch out claims like that. And with especially now, today, with PACT Act, what seems like 2 years ago, which is insane to say, well, I guess a year and a half, there is technically still a backlog, but it's not as much as they thought it was going to be, which is a good sign. There's still like 900,000 or something claims, right? So imagine you're being a rater. You got 30 claims to get through today. Answer this question yourself. Are you going to agree with the prompt and go fast? Or are you going to be like, you know what? I'm going to control F this veteran's, VA medical records, and then make a recommendation to increase or lower that. No, the likely scenario, I'm not saying it's right. I'm just saying the likely scenario is the rater is going to agree with the prompt because they don't have to justify it. It's easy. And it gets back to the 38 CFR. Now that was a rant, Jason. I feel like I ranted, so I'm jousting back to you. Right. Let's go with veteran A and veteran B example. Yeah. And I'm looking forward to what you're about to say.
Awesome. So number one, I want to add one thing to what you said, and it's short, don't worry, is we tend to think we know what the VA wants to hear because we heard somebody say something somewhere. Yeah. It doesn't always apply, right? It might have been a situational thing for a specific situation. The VA doesn't care really on how much your migraines are affecting your daily life and you this and you that. I can't ride a motorcycle and I can't play with my kids. There's nowhere in the schedule of ratings that assigns the 50, 30, or 10 does it say can't play with kids or your life sucks now. Solid. Those are not the words that it's looking for. Now, yes, it can affect those things, so don't get me wrong, but you need to have the right words to be able to add in there, which then, of course, makes the VA's job easier, right? So we want to make it as easy as possible. So I'm going to give you the quick A and B, right? So we'll use GERD, and both veterans, A and B, both have GERD, both have it documented enough for service connection, so that part's fine, okay? Because remember, CMP is for two things: getting service connected and getting the appropriate rating, okay? There's too many times where you're like, Why'd they rate me so low? Well, it's probably because you missed saying something. Now, ideally, like Clay had mentioned, you have already front loaded all of this information with your primary care provider. Okay. All this stuff is in there. Maybe you even went and got a DBQ completed by your primary care provider. And this is stuff we talked about in the past, both I think on this channel and our own personal channels, which is very important. I mean, you want to swim upstream with this stuff. You can still correct it at the C&P exam if you didn't do it up front, but it's way better if you're just doubling down on the information just over and over again, saying the same stuff. So now you're at the C&P exam. You're already primed for service connection. That's not an issue. Veteran A is just going with the flow. Maybe he heard some things somewhere and he thinks he's prepared enough because he has a buddy that got service connected for a bad knee. Right now he's going in for his GERD, and the C&P examiner is having some conversations with him, and it's just kind of conversational based. It's not like they're testing you with anything. You're just sitting across the desk having a couple questions, and they're answering. They're filling in the blanks, right? So they're just answering. You're answering the questions. They're asking you questions based on whatever they have on their computer, and basically the questions are, tell me about your GERD, right? Tell me about besides the fact of making it service connected, what kind of signs or symptoms do you have? Loosely is what they're asking, right? Tell me how it's affecting you. They're not asking, well, I can't play with my kids, right? They're asking you legitimate signs and symptoms that the VA is going to be looking for, but they're not going to tell you the words that they're looking for. So you need to be able to say that. But Veteran A didn't prepare. So Veteran A says, it's bad heartburn. Okay, great. Is there anything else going on? Well, it's really bad heartburn. Is there anything else? Well, it's really super, super bad. Horrible, horrible, horrible. Keep you up at night. Horrible heartburn. Okay, well, all you've said is heartburn so far. And then maybe they push a little bit more, and then you throw out something like, well, it really affects my quality of life. Like that's really going to matter. They don't. That's not even a thing on GERD, right? So, okay, the C&P examiner is now like, okay, look, I've asked you 17 different times on how this is affecting you. You've given me heartburn and it affects your life. Okay, cool. Thanks. Have a great one. Off you go. Now, Veteran B comes in, same situation, but this veteran actually read the schedule of ratings and is able to regurgitate the information. So now they're sitting in there and they're asking them, so the same questions, and the answers are a little more than heartburn. They're saying, well, I have heartburn, I have regurgitation, sometimes I vomit, sometimes there's some blood in my vomit. I've lost weight over the last couple of years. I have pain in my sternum. I have pain that kind of shoots. I feel like I'm having a heart attack. The pain in my chest kind of shoots down my arm. It's been really horrible. I really feel like there is just a considerable impairment to my health because I understand that it's eroding my esophagus and, it can result in cancer, right? So now you've named off like 5 or 6 different symptoms of GERD that are actually listed in the schedule of ratings for GERD. And that's going to align more with a 60% rating, for sure a 30, but probably a 60% rating, where Veteran A is going to get maybe a 10%, So the difference, even if you're exhibiting the same things, it's what you're saying that matters. And they're looking for specific words. I'm a big fan of, look, this is not some sort of closed book test, right? It says exam. And so we all freak out and go, okay, let me write the, answers on my wrist or something, No. Write it down, take it in. Everybody thinks that we all have TBI, so who cares, right? Show up and be like, look, I this is really important to me. I wrote down a few notes so I don't forget, because believe me, I forget where I put things all the time. How am I going to remember everything I need to say to C&P exam when I'm already stressed out? It's not going to happen. Write it down, take the pressure off, show up prepared, and just answer the questions with the relevant information needed to get you not just service connected, but the correct rating. All right, there's my joust back, buddy.
Yeah, no, that was absolutely solid. I'm a huge fan of yes, understanding 38 CFR, obviously, but more specifically, understanding you